Okay, so today we're going to be talking about whether antidepressant drugs and really other psychiatric drugs, can they contribute to mass murder, mass killings? And the reason we are talking about this today is essentially that we had a tragic incident that happened over the weekend. Someone plowed into a Filipino street festival, tragically killing 11 people. Now, I commented on this and I did a tweet, essentially that the role of psychiatric medications in inducing homicidal behavior should be considered given the horrific act of violence and the patient's significant mental health history. And I even went further then. I said that any mass killing event really should involve an investigation that looks into the roles of psychiatric drug-induced violence. And well, this struck a nerve because I had multiple different doctors and other folks out there essentially scream at me. And so there was a lot of abuse first, people saying a whole bunch of nasty things and, how dare you this and that, but no one really kind of commenting on the issue at hand. And so really what this talk is going to be about is there evidence actually that these drugs could lead to mass murder and homicide? And given, all of the drama over on X, I think this is a great opportunity to review some evidence. And so I think the best place to start really with this is what we already know, and that's what's in the drug labels. And so this one here, we're looking at Strattera, and here is a part in the warnings and precautions. So, one of the most prominent sections in the label that talks about the risks of the drug, essentially saying that patients treated with Strattera should be monitored for the appearance of worsening aggressive behavior or hostility. And that if such symptoms occur during treatment, you have to please consider a possible causal role for Strattera. Now, I'm familiar with this one because I wrote this. I used to work at the FDA. This was my analysis that ended up updating the language here. So I'm very familiar with doing investigations into drug-induced aggression. Let's move on. Let's talk about Abilify. Now, if you go into the adverse reaction section of the label, you'll notice that there's a line there for psychiatric disorders where it says that homicidal ideation can occur here along with aggression. Yes, it does say it's rare, but that's in the drug label as a risk. And finally, if we go and look at the patient advice in the warning labels for drugs, this one's actually for Effexor. You'll see in this section, it says patients, their families, and their caregivers should be encouraged to be on the lookout for anxiety, agitation, panic attacks, insomnia, irritability, hostility, and aggressiveness. And if we go to the last sentence, symptoms such as these may be associated with an increased risk of suicidal thinking and behavior and indicate a need for very close monitoring and possibly changes in medications. So, starting from a baseline, guys, it's well known that psychiatric medications can cause suicidal thoughts and behaviors. It's been known for a long time. It's also well known that the drugs can make people aggressive and hostile. These aren't very common side effects. These are rare side effects, but these are well known. They're known by the FDA and the drug companies. Now, there's this thing out there where people will say, oh, well, it's not really true. Drug companies, they just put this stuff in the labels because they have to, they just really want to protect their ass. Listen, guys, I used to work in the pharmaceutical industry. We're not going to give our competitors ammo against us if we don't need to. In a crowded market like in psychiatry, if you start putting this stuff in your label and the competitors don't have it in there, they start bringing that to doctors and saying, hey, don't use this drug. It makes people homicidal. And so that is bogus. But I mean, let's also, that aside, because drug companies don't get to decide what's in a drug label. It's actually the FDA. So let's look at the guidance for industry and the threshold for putting something in there. Now, this is out of the both the guidelines, but also the Code of Federal Regulations. This, the top part of this is a regulation, and it says you have to include events for which there is some basis to believe there is a causal relationship. Now, what does some basis to believe there is a causal relationship mean? How certain is that? Well, it's actually not really spelled out, but it's actually believed to be less than 50%. This may seem kind of academic and esoteric, but we have different thresholds of causality when we want to say something is related. You may have heard about beyond a reasonable doubt. That's a 90% causality threshold in a criminal trial. You may have heard on the balance of probabilities. That's 50%. That is in civil cases. Now, when it comes to drug side effects, and remember, this is what I used to do for a living, it's when there's some basis to believe. While it's never exactly spelled out, it is believed to be less than 50% certainty. And they do it this way on purpose. The government wants to be more conservative with the recognition of these side effects. Now, I know there's a lot of people out there, especially the PSSD people, screaming at me, being like, no way, they're not doing this. And that's true. The reality is, whenever there's a drug that makes a lot of money and there's a lot of interested people there in protecting it, all of a sudden this some basis to believe thing, creeps up to beyond a reasonable doubt. So it doesn't really follow what the law is meant to say. That's just the reality when people want to make a lot of money off drugs. So it goes down, and here it talks about the factors that people look at when they want to know whether a drug is related. So, for instance, the frequency of reporting, how commonly it's reported, whether adverse events rates for the drugs exceeds the placebo rate, so an imbalance in events between drug and placebo, whether there's a dose response, meaning, the higher the dose goes, the more events there are seen. The extent to which the adverse reaction is consistent with the pharmacology of the drug, the timing of the event relative to the timing of the drug exposure, the existence of challenge and de-challenge. This simply just means, when you get put on a drug, does it emerge? And if you remove the drug, does it go away? And whether the adverse event is known to be caused by related drugs. This is the cornerstone of drug safety research. This is the sort of the causal framework through which drug safety scientists will look at things. And so let's, so I just read all of this a moment ago, but let's go into this for drug-induced violence. So if we're going to talk about the frequency of reports and drugs and placebos, obviously, guys, I can't do, looking into every single drug out there. So we're going to look at what was found in Paxil. This is paroxetine. It's an SSRI antidepressant. And when they've looked at hostility events in placebo-controlled trials, as you can see, it's a rare thing to be reported, like 0.5% here and then, 1/3% here. But if you look at all of these things, there are always more hostility events in the people who get the drugs. Sometimes they rise to statistical significance, and sometimes, it's just a trend, moving in that direction. But in all of these cases, there's more hostility events on the drug than the placebo. And that makes sense because, what do we know about these medications is you can have paradoxical reactions, and sometimes people can become hostile on them. And so, we can have a look at, this imbalance here and the frequency of reports. And so as you can see, it's not that frequent, but listen, when you put, 14% of the US population on these things, you're going to see it. This is something really important that I want to talk about. This may be a little technical, but I feel like the people that follow my content like things that go into a bit more detail. And so what I'm talking about now is some of the problems with epidemiology. Now, the reason I'm doing this is because people think that randomized controlled trials are the best way to detect problems between drugs. Like, they will completely deny everything else out there, no matter how plausible. If it's not found in a randomized controlled trial, whether it's, an imbalance isn't found, they will simply be like, oh, it's not real. And here's the reason. I'm bringing this up because most of the people who deny that these drugs can cause violence or mass killings or anything like that, they usually use clinical trials. So even though I showed you this one where these clinical trials showed an imbalance, they'll find a different one and they'll say, well, in this one, there wasn't an imbalance. Or they'll do a observational study or a database study where they'll look at 20,000 people and they'll say, look, the people who were on the drug versus the people who were off the drug, there's no difference in violence. And that's why you shouldn't say that there's a causal relationship. Well, let me just show you how shit randomized controlled trials are in detecting events. And it all comes down to what I like to call the fact that psychiatric drugs can have dual effects. So, for instance, do you think it's potentially credible that if you put someone on a drug that in the vast majority of people actually kind of blunts them and reduces, their emotional reactivity, that might actually make some people less violent? I'm going to pause for a second here. I would say that's potentially true. I would say that's true for suicidal behavior as well. I completely accept that these drugs in some people may reduce suicidal thoughts and behaviors, especially in the short term we're essentially using drugs to mask unpleasant symptoms. And so that's what I'm really showing you here. If you look at these two boxes, this is like a normal randomized control trial. You have 1,000 people getting the drug and 1,000 people not getting the drug. This top blue line is the background rate. And so we're going to say the rate of violence is, I think that's 7 out of 1,000. And so this is just the background rate that's expected to happen in both of those groups, no difference. But when you introduce an antidepressant, well, look at this. Maybe 4 of these events are going to be avoided because of the beneficial effects of the drug. Could that be possible? Yeah, it could be. But let's look at the other side. Maybe there are 3 people who have a paradoxical reaction to that medication and actually become worse. These are the folks who would not have become violent, but are now becoming violent because for genetic reasons, they're just susceptible to the drug. And because they're exposed, now they have it. And so when you look at this, if you go to the next slide, so these green ones will cancel out this normal background rate, but you still have the additional 3 that you get because the drug induced the problem. And so at the end of the study, you could get, 6 violent events here and 6 violent events there. And someone's going to say, well, there's no difference there. There is no difference between the two groups. Obviously these drugs don't cause violent behavior. Now this can happen with suicidal behavior, violence, or any of these sort of behavioral things that these drugs can do. But you would be wrong to conclude that these drugs can't cause those events, solely based on the number of events in the 2 groups, because in one group there's dual actions going on there. And this is why clinical trials, especially randomized placebo-controlled studies, which everyone thinks are the gold standard, are really, really not good when it comes to detecting, behavioral changes. This is why, although we had lots of case reports in the early 90s, we did not recognize drug-induced suicidal behavior on antidepressants until 2005, 15 years later. And there are still some people who deny that this is real, and they say it's controversial because they don't see it in these studies. And so I know that was an aside, but I just want you to know this is the worst place to go and look for causal evidence for an association for things like violence and suicidal behavior. Okay, so outside of those sort of clinical trials, let's look at the extent of the dose response. Now, I'm just going to sidestep this one. This isn't that relevant for drug-induced violence. And the reason is it is not a common side effect that everyone experiences. You're going to see a dose response in something like, a drug that causes high blood pressure, right? If you take, more and more Adderall, you're going to have, the more you take, the more it's going to increase the amount of high blood pressure. With antidepressants and things like violence, akathisia, suicidal behavior, these are, we call them idiosyncratic side effects, meaning they don't happen in everyone. They only happen in people who have this genetic susceptibility to them. And so because of that, you're not really going to see a dose response there. But that aside, the extent to which the adverse event is consistent with the pharmacology of the drug. Now, if we were thinking about antidepressants and violent behavior or homicidal behavior, is that consistent with what we know about the pharmacology of the drug? Well, yeah, it disrupts the serotonin system. The serotonin system plays a large role in mood. We know that by disrupting the serotonin system, it has led to impulsive suicidal behavior. We know it's led to people going manic and psychotic. All of this is in the drug labels. So it's not really that much of a stretch to say, if these drugs can make people manic, impulsive, psychotic, suicidal, could they also make people violent, maybe even homicidal? That's not a stretch to me. I think that's common sense for most people. The next one, whether the adverse event is known to be caused by related drugs. Well, we looked at this at the beginning. Strattera, that one causes, aggression and violence. Abilify, they found, homicidal ideation when they were looking at that. And in fact, if you look at all psychiatric drugs out there and even drugs of abuse, in rare instances, these drugs can make people violent. And so I would say, psychiatric medications as a class can cause paradoxical events that make people violent. So I'd say it's a yes there. And then finally, we want to look at individual cases. And we want to look at challenge, de-challenge sort of experiences. And And so that means, the guy gets on the drug, it happens, they come off the drug, it goes away. But we also want to look at that along with an absence of plausible alternative explanations. And so this requires really good case histories. And thankfully, David Healy has supplied them. So the reference for all of these are up here. This is all from the same article here. I'll move my little thing. So if you want to read more of them, you can. But here are 4 cases. Now, the reason I'm choosing these cases is because these were either judge or jury verdicts. So these are meant to be impartial. Lawyers went up to these people and they made a case for whether the drug was involved in the violent behavior. And I like this because juries and judges should be impartial. We have to believe in that system. And if I just pulled out case reports from the medical literature, someone's just going to say, it's just some biased academic who, who just wants to make a name for himself. No, these are real cases that went to trial here. And so let's see what people found when they heard the evidence. Well, this first one was about Donald Shell. This is a 60-year-old man from Wyoming with a prior history of depression, no history of violence. He was prescribed Paxil, and after 2 doses, he killed his wife, daughter, granddaughter, and then himself. He had a prior history of a bad reaction to fluoxetine. He never should have been put on another SSRI. Paxil and Prozac are both SSRIs, and if you respond badly to that first medication, you have agitation or hallucinations, there's a good chance you're going to have a side effect to the next one. And so the doctor who prescribed it for him didn't know he had this previous bad reaction. He got put on it, and then 2 days later, after 2 doses, he essentially killed his whole family, and then himself. Now, his son-in-law, Tobin, brought this verdict that actually against the drug company for failure to warn. And so they took, this is SmithKline Beecham, that used to be GSK, and the jury found them to be 80% responsible because they did not warn in the labels that these drugs could result in homicidal suicidal behavior. Tobin ended up with a $6 million verdict in his favor. It was appealed and it did not pass. And so it stayed. And so the jury in this case found that this was likely a drug-induced murder-suicide caused by akathisia on psychosis. Some people get picky about that. They don't want to hear it as suicide because it really isn't. This person didn't want to kill himself. He was delirious from the drug, but I'm going to use that word anyway. Next case, we have an 18-year-old woman who was grieving her grandmother's death. She went from 20 to 30 on Paxil and became rapidly drowsy, agitated, and aggressive. She assaulted someone in a nightclub shortly after the dose increase, and afterwards, her behavior normalized after stopping the drug, so it went away. That's the D challenge. She was found guilty, but the court acknowledged the antidepressant contribution, and so she was not punished as much as she would have been. And the mechanism in this one was likely treatment-induced akathisia. Next case, we have a 74-year-old man with mild depression and anxiety, was put on 50 of Zoloft by a locum doctor, took 5 doses in 1 day, woke up, strangled his wife the next morning. He had had a previous adverse reaction to sertraline. So yeah, just like Donald Shell. And this is called a re-challenge. When you have a bad reaction to a drug and then you take it again and the same thing happens, that's positive for re-challenge. That's about as good causal evidence as you could ever hope to get in anything. If you're going to say, this is related to the drug, you remove it, it goes away, you bring it back and it comes again. And so that's what they found. They found a positive re-challenge here. He ended up pleading guilty to manslaughter, but was immediately released. And the judge in the case said, if not for the Zoloft, he would not have strangled his wife. And so this was likely treatment-induced akathisia or delirium. And so again, we have another case where this has changed the outcome for punishment. And so the final one that we'll talk about, and there's many more actually listed in David Healy's report, but we'll stop here. This is a 33-year-old woman, history of untreated anxiety, started on Paxil, but then switched to Effexor, 300 milligrams a day. Shortly thereafter, worsening agitation, and she planned a murder-suicide with her children. She attempted to carbon monoxide poison them, but then stopped herself and sought help. When the judge looked at all of the evidence, she was given a suspended sentence, and the judge essentially said this would not have happened if not for the Effexor. And so she did not go to jail, even though she did something terribly heinous, because it was found that the medication was involved. And so this was likely a case of treatment-induced akathisia. Now, this is not to say, everyone who commits a murder or a suicide on these medications was having a drug-induced event. These are these are likely exceedingly rare, and many people have gone before judges and tried to argue that this was the case, and it's not been credible, and it hasn't made a difference. But this is just to say that there are many cases out there, which have been reviewed by impartial juries and judges, which have found that these drugs have been involved in suicidal and homicidal behavior, and it has changed their judgments. So let's move on. So with all of this said, could drugs that cause suicidal behavior, violence, mania, and psychosis lead to homicidal behavior and mass killings? Absolutely, without a doubt. And really, we don't know how common this is. I mean, if this happens, in 1 in a million people, if I do some quick math off the top of my head, given about 10-ish, there's 14% of the people taking these medications, I mean, we're looking at, 30 to 50 of these things happening potentially a year. And that's with 1 in a million. I mean, it might be 1 in 2 million, less than that. It does not matter, how exceedingly rare it is, simply just that it could happen. And when it involves, shooting up a school or plowing into a bunch of people, we need to be asking these questions. And so, without a doubt, I think these drugs have the potential to lead to mass murder events. So why the conflict? Why is it that when you sort of attack this sacred cow, which you're not allowed to talk about, people lose their minds. They become very, very upset, and they start to attack people like me and others who bring this up. So this is a sacred cow, and the reason you cannot question this, I mean, this is my opinion now, but I'm going to talk about it, is because if you did so, it would make us look like a bunch of clowns. And I'm talking about psychiatrists, because as soon as you acknowledge that prescribing these drugs could potentially make people homicidal, it calls into reason, how we prescribe these drugs in the first place. Most people will get one of these drugs after like 7 minutes of FaceTime with a family medicine doctor, and then they will not ask them about it at all after that. They rarely give them informed consent. When you go to the pharmacist doesn't talk to you about it. They shove like a little piece of paper or a keyboard at you, and you click yes, which says that you were given a chance to acknowledge, to ask about the risks. So there's no informed consent. We hand them out like candy. About a year ago, I did a sort of a video walkthrough of me going through the HIMSS platform, where I was able to get Lexapro essentially without talking to anyone, and probably only talk to a bot, and it was mailed to my house. There was absolutely no informed consent there. And, 14% of the US population's on antidepressants, nearly 20% of them, probably more, take psychiatric meds. We do not monitor people correctly for them. We do not bring their families in and say, hey, if there's a behavioral change, bring this person back in, because that's important. They may not realize it's happening, and so you need to keep an eye on them just to make sure they're safe. We never do this. And so if you would acknowledge that these are risks, it essentially makes us look like a bunch of clowns, and we are. We're not doing proper due diligence with these drugs. This is why I don't think family medicine doctors should be prescribing psychiatric drugs. They simply don't have the time to do it right. Number two, for the academics out there who like to, shit talk this, I see this not just with drug-induced homicidal behavior, but any time we talk about risks of these drugs, it is bad for academic psychiatrists out there to say these things are real. It's bad for their careers. I mean, many of these people have made their careers running clinical trials for pharmaceutical companies, and that's one of the best ways you can get promoted. You can get promoted. You sort of get lulled into it. And you don't want to talk about this stuff. You don't want to believe it. And if you've been practicing this way for a long time, you don't want to admit it to yourself. They're often always, friends with other academic psychiatrists who may be even more involved with the drug companies. And to even bring things up like this would lead to ostracism. And so it's this kind of tight ball where they care about their careers, and they don't want to step out of line, because it could jeopardize their relationships. And so they won't talk about it. And on top of this, they enjoy denying it. And their favorite excuse is to say that they are preventing stigma. Because if you bring up the risks of psychiatric medications, obviously you're trying to say, mentally ill people, people with mental health diagnoses should pull themselves up by their bootstraps. It's such a load of BS. As if giving people, the informed consent about the risks of these drugs is stigmatizing them in some way. Most people would want to know all of the important risks of these drugs And I think behavioral changes on psychiatric medications that can potentially lead to suicidal or violent behavior is something, even though it is very rare, that is important enough that people deserve to know about it. Now, let's talk about how people have been denying this. Well, one of their favorite things to do, as I mentioned before, is to grab epidemiologic studies. One of these was sent to me by someone who was arguing with me on X. And essentially, it was what I was explaining before. They did a database study. It looks like they looked at 160,000 individuals. Actually, they looked at 20,000 individuals with personality disorders who were on psychiatric, who were on antidepressants. And then they looked at the time that they were on drugs versus off drugs over a period of probably several years. And then they said, did more violent events happen when they were on drug versus off drugs? And for this, they found violent crimes did not observe any association in any direction. And so this was the evidence this person was trying to say, look, we've done this epidemiologic study. There is no evidence here. And they will grab things like this. And then they will say, despite there being all these jury studies and this, biological plausibility and these clinical trials that find this association, they'll cherry pick their favorite epi study, and they'll say, well, it wasn't really seen in this one, and so the whole thing is fake. And this is essentially what people used to do with smoking and lung cancer. They would just grab one study and then they would use it to cast doubt on something because they were getting paid by the cigarette companies. And so this is the hierarchy of evidence. I bring this here because I know some doctors and scientists actually look at some of my content as well. And this is the reason why some people feel like they can grab a clinical trial or an epidemiological study and say, well, this one didn't find it, and now everything else is irrelevant. This is called the hierarchy of evidence, and this is from EBM. And it essentially says, case reports are at the bottom, RCTs are at the top. Well, as you can see, the devil is in the details. RCTs can be absolutely useless if you have a psychiatric drug where the effect can go in both ways, meaning it can help people and harm people. And that's the exact same with the epidemiologic studies as well. And so if you're actually a drug safety scientist, you know these things. I mean, you understand the nuances of how the clinical trials are done, and you realize that, some pyramid like this isn't really the way you kind of break down these things. Yet you have to do it almost like a judge or a jury would. You have to evaluate every single little piece of evidence, and then you make up your mind. And so this pyramid is responsible for many people out there completely misunderstanding how to actually, look at causality. I mean, sometimes the pyramid's right, but in this case, it is wrong. Another thing people like to do to deny the, whether these drugs can lead to mass shootings is they'll get articles like this that really do seem to be biased for me. So this was a big one that came out in 2019. It was called The Myth of the School Shooter. And it sounded pretty good. To determine if there was any validity in this assertion, the authors of the article reviewed publicly available information regarding individuals involved in educational shootings from 2000 to 2017. They looked at, news reports, court records. They used Freedom of Information Acts and all of this stuff. This is great. This is exactly what people should be doing. And then they concluded, and this was in the abstract, from the information obtained, it appears that most school shooters were not previously treated with psychotropic meds, and even if they were, no direct causal association was found. Wow, this sounds like, case closed here, move along, people. And it's only when you actually go and look at the nitty-gritty, and this is kind of further down in the paper where they talk about the limitations that you learn this. And let's read about actually what they found when they did their analysis. It says, unfortunately, not every FOIA request resulted in documents, and those that did often had parts redacted. And even when, for a FOIA request, psychiatric information or the records were not always included. Efforts to obtain primary legal documentation from the original trials were largely unsuccessful due to the perpetrator's age and the sensitive nature of the information. In several instances, it was possible to determine from reviewing court dockets that experts were retained or reports were written, but the information in the reports were unavailable or sealed. And so essentially, it goes on, But the person who did this study was operating off incomplete information, heavily redacted information. And we can only speculate as to why someone would want to draw a conclusion like that when they did a study where they really didn't have all of the information there. I mean, again, this is a highly charged political topic, and so I'll let you imagine why they might want to come down that way. But usually it's because they want to blame drugs, and they're just very one-track minded. Anyway, this is the reason why I was so excited when Emmy Miller from Children's Health Defense actually sent me this the other day, which showed that just 4 days ago, the common sense governor of Tennessee, Bill Lee, signed a bill into law saying that they need to investigate the role of psychiatric medications in mass shootings. And this passed by a landslide with bipartisan support. And this is why, because when people go to look at these things, it's just redacted and they can't get it. They don't get complete information. And I think it's completely logical to wonder, what are the consequences of, 20% or maybe even higher of the US population being on psychiatric drugs? Could this lead to school shootings? Can this lead to acts of mass violence? We are never going to find out unless we start doing these things. And when you start doing these things, maybe you find that in one instance this happened and in several others it didn't. But then you can use that knowledge to go to the state, and create laws such as, if you're going to put someone on one of these psychiatric meds, you need to have informed consent from the patient that these things can happen, and you need to have informed consent from a loved one. By looking into these things, that is how you can get the evidence to make these changes and actually improve public health. And so Tennessee is great. Thanks, Governor Bill Lee, for doing this. I think it's the right move. And so I'm going to conclude there. I mean, that is my download on how these drugs can lead to mass killings. Comment below. Let me know what you think. Thanks.